Thank you for being so attentive. I really appreciate it. I'm Alan Blum, and I'm professor and endowed chair in family medicine. My 24th year, and I'll tell you about this talk. It's actually a double whammy because we got this, and thanks to Jeremy and Afreen, I've got this same double session that we had in July when I talked about the ABCs of cigarettes and e-cigarettes. So this came about in the 1990s when Dr. Nick Gervanos, who ran this Lancaster Family Medicine Review course, one of the most well-attended in the whole country, and I'd given a lot of talks there, but he said, come on, Alan, do something totally different. And I was struck by the fact that in all the charts I review at Baylor when I was on the faculty there, very seldom are there oral diagnoses made. I don't recall any talk I ever had in medical school or in residency on oral diagnosis. Has anyone here, have you had that at all? Anybody sort of taken an interest in that area and asked for more instruction? Because, you know, apart from going to dental school, I don't know as though we get that. And full disclosure, I did spend 1 year at Emory University School of Dentistry. Don't get me started on how that came about. The world's only English major that ever went to dental school. And I didn't, it wasn't for me. I didn't want to put my life in my hands, and I was able to move over to the medical school. But in any event, so I've always had an interest in the oral cavity, but I haven't seen it reflected in the charts that we review. And for instance, in the diabetic exam, you know, that's so crucial. Now, I know we've been masking for the last few years, but as the masks come off, that's my appeal today, to take a look at that mouth. And before you head right to the pharynx, take a look at what's in front of it. And that's what we're going to go over. So every few years here, I get to do this, and I've done it at a few more review courses, but I get to revise it. So this is substantially revised from the last time that I did this in December of 2019. You're going to get some handouts, more than you ever wanted to have. Among them will be this sort of glossary of some of the things we'll talk about today. You'll get a whole collection of articles from AFP that I've found over the last 30 years on aspects of common oral lesions, dental emergencies, signing out for the dental procedures that people need, and so forth. I also have in my office these 3 really great books on oral pathology, and they're incredible atlases. So with that in mind, let's take a look at oral dermatology, and I'll give you some objectives. Keep in mind, unfortunately, that dentistry is a luxury. Only half of Alabamians see a dentist once a year, and fewer in rural areas. You're as likely, as a dentist, to be that first connector and making these diagnoses. Isn't it amazing that over 40% of people over 65 have lost all their teeth? And by the time you're 18, it's been estimated that 12 of your dental surfaces have caries. By 40, it's 30 surfaces have either been treated for caries or recognized to have caries by the dentist or the physician in the office. This is not an inconsiderable problem. Oral disease and even caries is a major source of work days lost. I hesitate to say disability, but I think there's a substantial problem here that is underestimated. And if you really want to be very specific about it, the specific condition of periodontitis in pregnancy is well associated with low birth weight babies and upwards of, nobody can say exactly, at least 1 in 8 preterm deliveries. Then don't forget, there are lots of psychological issues. As with dermatology in general, every condition that you can see has a kind of psychological overlay that people might not want to share with you. Untreated caries, there you go. Just take the diabetic patient, for instance. They come in an evening clinic with pain. We give them analgesia, mouthwash, and maybe an antibiotic. But that leads to infection that often they're not going to go and get treated. Dentistry is expensive. Maud Watley, where I have a patient who's one of the dentists there, they do great work, but you got to get there early. They turn people away. but the infection can lead to loosening of the ligaments around the teeth, resulting in tooth loss. You can't gum a steak, you can't gum your meals, and yet a lot of our patients are there with edentulosum. It leads to emergency room visits, if not here on evening clinic, worsening diabetes. Upwards of 30,000 cases of oral cancer will be diagnosed this year. You say, well, that's about 3 to 6% of all cancers. A third of them will die from that condition. And anything you discover, the great thing about what we're going to talk about is anything you discover in the mouth that doesn't look quite right to you, note it, because it may be a subclinical process. So we know the anatomy, but let's just review it again. You've got the enamel on the outside, you've got the dentin just below it. Pulp is the core where you have a root canal if you're having this pressure, this infection that's causing pressure there and you're intense pain. Who's had a root canal? Good, not that many. I've had it, and it's even people who brush and so forth. It's something that you get. I didn't mind the procedure. Did you? Did you?
Mine was better than any feeling I ever had. Like they just numbed it completely. I didn't feel anything.
Yeah.
Maybe I got that just garbage, and that's why I got the root canal. But
it's a meticulous surgery. It's fascinating and it's great because they're replacing that infected pulp with an inert substance, and you're well again. It saves the tooth, but it's a big deal. But I'm impressed with the procedure, and I didn't find it particularly arduous, but it's not unserious. And then you have, in the bonding of the tooth into the alveolar ridge. This area here is the sulcus. That's the key thing to be looking at on a clinical exam. That joint of where the tooth and the gums meet. You've got the bone. We'll talk about osteonecrosis. And then you've got this periodontal membrane insulated with cementum, nerves and blood vessels, and the end of the root opening into the bloodstream. How many teeth? Deciduous teeth? 20 teeth. I know this is something you go over with, but it's so crucial to just have a general idea that in that first year you ought to have an incisor. By the second year, they all pretty much, including your second molars, ought to begin getting in. This is how the dental exam is done. This is how we should be examining the oral cavity. It's counterintuitive, but you'll find it much easier to observe. And the adult teeth, 32 incredible individual organs, just be aware of what their normal alignment is, because a lot of what we see is simply misalignment. We often can't get back and see those third molars, but it's important because of a condition called pericoronitis, where you sort of see something back there. It looks a little red, the tissue over it, but that's part of that unerupted molar that didn't get in and it's causing a lot of pain. You see this in teething, in deciduous teeth, where infants are crying and you think, well, it must be teething. Not necessarily. It could be pericoronitis, which is an inflammation/infection. And of course, the main thing that we've got to be on the front lines for is the baby bottle tooth decay. Wean those kids off a bottle, substitute a cup within 1 year. Don't put any child to bed with a bottle of any kind. Clearly, water is not going to cause any damage, but even breastfed infants shouldn't be, falling asleep with mom in the bed. It's just not. There's a lot of liquids with sugars in there that are going to lead to some de-enamelization and caries. So we are the key to detection. Again, I've mentioned misalignment. Don't overlook the lost teeth. Document, if you can, the lost teeth, the bad breath, the trauma, mouth breathing. These are all just descriptions. And pretty amazing looking at just 60% of adolescents with gingivitis. The gingivitis, the good news, is really just inflammation. It can be well treated with any number of mouthwashes. Peridex is one. And that's a good controllable condition that you can probably control and treat in just one visit. But nobody's told people about it. In adults in general, we see something that we don't often see described on notes, which is root caries. And you'll see the recession of the gum. You'll see plenty of pictures today, and you're seeing the exposed root, and that's prone to decay once it's exposed. Dry mouth is a common cause for medications, as well as chemotherapy. Obviously, when people have eating disorders and they're constantly vomiting, like hyperemesis gravidarum, they're getting exposure to the acids from the gut. So dry mouth is very common, and that's a source of caries. Keep in mind, I didn't put the whole list of medicines, but that's a big problem. I can't say that in a given instance it's caused by a medicine. But keep it in mind, when you can't figure out another cause, that possibly a medication might be at the root of dry mouth. Obviously, diphenylhydantoin is the leading cause of gingival hyperplasia. We see that if you look for our patients, particularly those with mental health issues who've been on anticonvulsants. And then the leading causes of malignancy are alcohol and tobacco. Don't overlook the alcohol as a cause of cancer. And one appeal is when you ascertain the patient has dentures, please, I know it's touchy sometimes, please ask at least once a year if they wouldn't mind removing it so you could take a look at the palate and the soft tissues. Again, caries we've talked about, broken, eroded, discolored, missing and malaligned teeth. We'll see a condition called hairy tongue, and that's just mainly coffee and cigarette users and so forth, but it has some other causes. And we'll look at a few masses that are perfectly benign, like torus and pyogenic granuloma, fibroma, and papilloma, and mucoceles, but we won't look at them out of context. We'll try to put them in the context of how they might be confused with a cancer. Candidiasis is not one just coated tongue. It's several different conditions. There's erosive candidiasis that can affect the palate. There's angular chylitis that you wouldn't recognize normally as the same kind of coated tongue, but it's in the corners of the mouth. And there's this median rhomboid glossitis. I'll show you a picture. You can't forget it. It's just this deep color. And it's a form of candida that's easily treated with the same fluconazole suspension, or that's preferable to the pills. Other conditions that we'll probably go over all of them, lichen planus, which has several forms, by the way, not just Wickham stria that you'll get on your board exam. Linea alba, lead lines, ranula, that's a fun term. Geographic tongue, I have a story about that. Aphthous ulcers, herpes lidialis, that pericornitis I mentioned, periodontal abscesses, leukoplakia, erythroplakia, keep in mind erythroplakia, and lithiasis, say that 3 times quickly. The same kind of lesions in the mouth or that on the skin. Just know these, maybe the most important slide of the day. Macule, vesicle, pustule, papule, nodule, plaque, and ulcer. Those are your primary descriptors. Start with them. Don't have to make a diagnosis, just describe what you see. And these are other tips to refine the diagnosis. I go a lot by history. I had a radio show when I was in residency and fellowship, and I could diagnose certain dental conditions because they were just so clearly related to the history and then the patterns of them. Obviously, the location, how widely it's distributed, whether it's local or all throughout the mouth, the size, the shape, the color, the consistency. That's where you got to glove up and feel, and the texture. So as an example, circling this lesion, it turns out to be, well, I can give you the answer, but here's how online this person documented this. She's a dental hygienist, and she's been there for 2 weeks, no known trauma. It's on the buccal mucosa just next to the third molar. I forget which side. Single, localized, well-defined, with an 8 millimeter diameter. A macule. That was just a round macule, oval really. It's blackish, bluish, and it's soft when you feel it, just like the, so it's no different with surrounding tissue, and it's smooth. Anybody want to hazard a guess? It's not important, but you've already described it as well as you need to do. You want to put a name to it? It's called an amalgam tattoo. It's from your filling, that's all. It could be from braces too. And this one maybe is more common than that. Again, you don't have to guess the name of it, but do describe it. It's been painful there for a couple of days. It's not the first time that the person's had it. It's at the right lower labial mucosa area. It's just one of them, and it's well defined with about a 5 millimeter diameter. It's a round ulcer. It's white with a red border, soft like the strand, and it's smooth. Want to hazard a guess? I agree. Keep in mind these aspects of the oral exam. The smile. Notice it when you walk in the room. When people aren't smiling, it could be that they don't want to show their mouth. And I have people, that sit there like this, and we know some of the reasons, but still, you're there to help. You're there to encourage. You're there to see, gee, what a nice smile. Or I can make this smile even better. I think you have a lovely. That kind of thing is truthful. We all have good smiles, and I think that if we encourage them and get people to open up, it can change their personality. One of the things that I think one of my major accomplishments here was to get the gooseneck lamps into every room. Pen lights don't hack it when it comes to an oral exam. Please don't say, well, I looked in. No, unless you used a bright light or a headlamp, you haven't done a sufficient examination. A tongue blade may or may not be necessary. I think you can get people to open their mouth and yawn. By the way, try it, and that actually, and unfortunately, then you'll start yawning and everybody gets tired. But no, it actually works if you say, please just yawn for me. But a tongue blade is necessary once you put on gloves, take a piece of gauze, wrap the tongue, and use the tongue blade to push the tongue to one side or the other. So you got to look at the lateral aspect of the tongue, which we don't often look at, and that's where most of the dangerous lesions on tongues are. And those are just the essentials for doing the oral exam. And then keep in mind what we're looking at. Have your own approach. So start with just the scanning away and looking at the whole face. Look around the mouth, the perioral skin. We know of a couple of conditions right off the bat that are perioral dermatitis. There's kids that have contact dermatitis from the teething and from teething ring or from just drool. And then you have looking at the neck, looking at your lymph nodes. Have your patterns ready. You're going to do submental, submandibular, preauricular, postauricular, anterior cervical, posterior cervical. Any way you do it, supraclavicular. Just have that order so you don't forget which ones. And then you want to have the texture of those lymph nodes in mind. We'll show a couple of examples, but keep in mind the firm, the soft, the rubbery as descriptors for lymph nodes. Don't forget the lips. Major, huge source of problems that we overlook because we're not used to stopping and looking at the lips purposely. And there are all sorts of spots and accretions and rashes. The buccal mucosa and the labial mucosa, that's where you might have to put your finger or at least the tongue depressor to take a good look at the mucosa. And the tongue, the teeth, the palate, the floor. And only then do I go back into the tonsils and the pharynx. And what's there also hanging down? Uvula. Except in one guy's case, he was very upset with me because he'd been into his wife's nursing encyclopedia, and he had an indiscretion, and he thought he had all sorts of diseases. And I probably did 3 visits with him, and I examined him, and I said, no, you're fine. And then he came back one more time. He said, did you look at my throat? I said, yeah, it's perfectly fine. He says, yeah, then what's that spot on my vulva? I mean, he didn't read it quite right, but, uvula. But, so I think that keeping the elements in mind. Don't worry about the diagnosis. Your description will be better. Okay, let's start here then. How would you take a look at her and describe anything that you think, well, might be a little concerning? I know. Anything at all? Not easy to figure this one out, but I just thought since it's...
Is she a smoker? There are wrinkles that...
Oh, that's interesting. Hadn't thought about that. I don't think...
Left lateral.
A left lateral...
Like her left, just left like.
Oh, her left. Her left. Is, like there?
Yeah.
Oh, so there might be a little something. That's interesting.
Like this color.
Yeah, what's in the center of the picture? What's the name of the thing in the center of the picture? Lips, yeah. As in lower lip, most prominently, right? And what's on that lower lip? It's a variegated color. It's not the same color, is it? It's hard because there's a flash here. But this top half of that lower lip is a different color. And what is this condition always, just about always, is on the lower lip only, and it's actinic cheilitis. Anything with the lips is called cheilitis. So this is sun damage on her lower lip. Give you some other examples of that. Now that you would stop and say, what is that? That guy's just either he's got some of his soup left over, but if you see it on the next visit, you'll say, that's an accretion, that's an actinic cheilitis, that's a lesion. In a second, we can mention how you treat that. But here's some other examples, a little bit more subtle. Unless you stop and look at the lips, you're not going to pick these things up. And we haven't been doing that the last 3 years. So these are 6 different examples. You see how crinkly, and there's a discoloration. This is dry and discolored in an edentulous patient. There's something there, plus all this lightness there, and there's a variegated color again, and there's more accretions. All of these are variations of actinic cheilitis. How do you treat it? Anything you want to say, anything at all, try it. I guarantee you it will be correct.
Stop smoking.
Stop smoking. Good, that would be one, but actually this is sun damage.
Oh.
This is primarily sun.
Chapstick.
Chapstick, seriously, emollients are fine. Now, obviously, if you've got an advanced condition here, emollients are only going to protect it from further damage, but they're not going to end the problem. So what are some other things you might have heard about? Just imagine that you had an actinic keratosis on your skin or your back, or same kind of thing. This is exactly what it looks like on the back of the hands that we see every day. What would you do?
Biopsy.
You could, to be sure. You're extra cautious. I think put it this way, if it were a macular lesion with a discoloration that could theoretically be a melanoma or theoretically be something other than an actinic cheilitis, you could. But I think you could go right to treatment. And just like we treat a lot of skin conditions without biopsy, what would you do?
Cryotherapy.
Cryotherapy would definitely be one. And there's good pictures in one of the references of just holding that little spray with a little nozzle right close to the lesion in a localized example. Cryotherapy on the lips, how about that? 5-FU, believe it or not, in my residency, and it's still useful, we used 5-fluorouracil topical medication that family physicians can use. It can go to surgery. There are other topical medications, but I think that gives you the idea that this is something we need to act and intervene. Okay, how about you can imagine one of my favorite slides here. This would be, it is nicotine stain. I had a patient the other day say, hey, everything on him was nicotine stain, even his elbows. You know, so, but we do see fingers, and we might as well take a look. Don't overlook that. Okay, so we know that this is the side of the patient's neck. What does that look like? No, you can say that. Yeah, mass is fine. Don't ever say anything that, unless you know what it is. In other words, mass, we start there. It's certainly a swelling there. Anything want to go further? You don't have to stop. You can stop there, but if you'd like to go a little further. So you begin to feel it, and feels rubbery. You note that. So what conjures up rubbery feeling? Well, it is a lymph node. What else? What specific kind? This is where you could actually be worried about Hodgkin's. Now, I'm not saying here, this is not an example of that, but rubbery is Hodgkin's. This is lymphoid hyperplasia. We don't know, it's a lymph node, but I don't know what it is. It might need a biopsy, but just to give you an idea, just keep it in mind, just document it. Don't worry about the diagnosis just yet, but don't overlook it, don't forget it. And how about this person? Looking up, you might think that's a most obvious thing. Just go to the simple word. Cyst. Would you want to venture to say what kind? That's what I would have thought. And in fact, this is a sebaceous cyst. So I only included, just don't have to worry too much. Just recognize it. If it's a thyroglossin cyst that is enlarging, that might have to go to a surgeon. If it's a sebaceous cyst, we could probably handle that. And I think, how do you distinguish it? You know, you could probably be able to put a needle in that and see what you're getting out. Now there we get into the more specifically named lesions. So we're going to start at the lips. And what do we see here? If you want to call out a diagnosis, or if you want to simply describe it, that's fine. Right? Any word?
Decay, plaque.
Oh, you went right into the mouth. Thank
I'm
you.
sorry.
Thank you. You always do. That's good. We're one step ahead. We'll stick to the outside right now. What do we have here? On the, there. A dome-shaped thing.
Could be either a basal cell carcinoma
Ooh,
or,
interesting.
or a pyogenic granuloma.
Interesting. So you're going right for the diagnosis. I would keep describing it. Is it tender? Is it, I'm not saying I could describe it looking at it, but it's red, it's dome-shaped. I begin to wonder if that could be transilluminated. It could be translucent. It's non-tender. It's been there a while, so you want to know more history. That's a very specific entity, and I'm glad you got some differential already. But is this benign or malignant? It's most likely benign, and it's most likely a mucocele. It's an interrupted salivary gland that's got mucin pouring into it, and that's what that is. Now, it's tricky on what you want to do with this. Dr. Owings, who was here for many years, would marsupialize these, and they would not grow back. But there's some doubt as to whether that is true or not. I just let them watch them unless it's interfering with their life. Some of them will resolve, but it's an interesting condition, and it's not just on the lip. This could be another example of a mucocele. It could also be a fibroma. I don't think it's malignant in any way, even though you could make a case for some kind of neovascularization. This, again, is most likely a mucocele. If it's really, really red and raw and inflamed, then that's where I begin to worry. Red in the mouth is not good. I don't like red in the mouth. It's redder than the regular part of the mouth. This turns out to have been a fibroma, a little fibroma. Some people call it a papilloma, but I think a fibroma is a more neutral term. Papilloma sort of implies viral. This is a fun one. Remember, I mentioned this in the overall list of things. Either you can tell me what it looks like, or if you want to go for the diagnosis, fire away. Where is it? It's in the mandibular area. It's below the tongue, so the tongue is pulled up. So it's below the tongue, and it's puffed up. So what animal puffs up? Frog. And that is called a frog. No, it actually is. It actually is, but it's the Latin word for frog, which you all know as ranula. So this is called a ranula. And stay tuned, because on December 6th, we're playing the medical metaphor game, and this might pop up. We're going to have residents versus faculty versus medical students. The med students are going to ace this thing unless you guys get a team of 3 together. And you might take a look at ranula. Okay, so it's perfectly benign, but imagine this is an interrupted, again, it's the same kind of thing of salivary glands having sort of exploded, and these might have to be tied down and opened and marsupialized. This is not a ranula, but this is on the buccal mucosa. It looks larger than flat, so it's a raised, bluish, looks to me like about a 1.5 centimeter elongated lesion. What would that think? How do you think through this one? You worried about it? Probably not. It's a varicocele, it's a nested blood, or some people would call it a cavernous hemangioma. It probably can easily be surgically removed. A lot of bleeding on this thing, but if you leave it alone, it's not going to cause any problem. It's not going to spontaneously start bleeding on you. And never say oops when you're operating on a cavernous hemangioma or doing a circumcision. As I once did when I dropped a piece of gauze, and the psychologist who wanted to see me do a circumcision, when I dropped the gauze and said, oops, he fainted right away. This is not a varicocele, but it's like a single vessel, varicose vein. That's all that is. Leave it alone. Now, we get into an interesting lesion that you will guaranteed see at least once a month if you look for it. So what's the clue in this picture? Just, step back and, so what are we looking at? And what's the dentures, right. So therefore, the hint is, this is something that's related to those dentures. And the retractors are showing you what that lesion is. So it's a denture-caused lesion called Epulis, E-P-U-L-I-S. It's an interrupted connective tissue lesion. It's literally kind of weird. It's a kind of dissecting connective tissue. It's been, if you put pressure on the gum, you're going to reshape the gum, and that's what that is. And it's not going to improve unless you refit the dentures. Somebody said what this is already, even if they hadn't seen it. They thought maybe the ranula might be this. So go right ahead. Tori. Tori what? Want to complete the full name? Because where is it located?
Mandibular.
Mandibular. Right. Tori mandibulare, or torus mandibularis. We love the Latin. So, what is it? Bone. Bony exostosis. Benign or malignant? Benign. Then what do you do about it if it's benign? People are coming out of their mouth and say, what is this? What do? Reassurance. But it's coming out of my mouth. Well, you might have to take it to a surgeon if they're wearing dentures, because the dentures cannot fit there. So it is benign. What is the most common condition? Well, I shouldn't say, when do you most commonly see tori? That you should know. Women, and what kind of women? In their pregnancy. So this is a common lesion, and it has to do with progesterone, and when they stop delivering, it gets better. But it doesn't go away necessarily. So these are other examples of torus palatinus in the palate. These are 4 other examples of tori palatini. Now, who would like to crack this? Well, give it a try. Just give it. What do you see? Very, very right around the teeth. Is that what you said? Is it red? Are we talking about this? Yeah. Any want to refine that slightly? I think that's a little closer because it's hyperpigmented. Yeah, darker. Yeah. So, what is the significance of this? What should you know about this patient? Anything at all? You can throw out any. Just guess it if you like. Put it this way: is it worrisome or is it? Which is it? Who votes for worrisome? Is it worrisome here?
Something you should do something.
Something you should do something else. So we have about a third saying a little worrisome. Who says benign? We have one person. Wait a minute, this is great. You know that it's benign. Okay, we got 2 benign.
I think it's because they have darker skin. Like
Exactly.
melanin.
Exactly. This is just called melanosis. Now, interestingly, depending on the depth of the color of the patient, the skin color is not reflective of the mucosal color, but invariably it is a person of color. Perfectly benign, as distinguished from what condition? When would you be concerned, such as in this 30-year-old man, about what he has around his teeth? Do you see what we're looking at there? Can you describe that? And you see it in the mandibular gingival areas. Those are classic, extremely worrisome. And why would you think so? Because it would be not the first thing you'd see. You wouldn't say, oh, I got these. This wouldn't be his first symptom. What would be his first symptom? Nausea, vomiting, stomach ache. This guy came in with pain in the back of his neck, going wholly down his spine, going down into his lower extremities and into his feet, and was admitted. Where did he work? In a smelter. What are these? Lead lines. Could be other heavy metals. Mercury, bismuth are 2 other examples. These are reversible. This is treatable. You can save his life if you do what? What's the treatment for lead poisoning? Chelation. So this is actually something that if you ever spot it, you will be able to save his life. Now that, again, gets us into maybe this probably is the most clinically important slide of the day. Why? Because it's probably the one you'll see the most if you look for it. So describe what you see.
Gingival erythema.
Gingival redness is fine. Great. Gingival erythema, yes. And I would even say it looks like they're pulled up a little bit. So that's a good start. Gingival erythema. And look how puffy they are in the mandibulas. Great pickup. What are some other things?
Discoloration of the teeth.
discoloration of the teeth. Be a little bit more specific. What's in those teeth? What do you see on those teeth?
Plaque.
Plaque. Really important to document that. What's in plaque? Bad stuff. That's where you have the streptococcus, I don't know all the different mutans, this is what interacts with the carbohydrates the kids are sucking in to destroy teeth. I mean, you're looking here at pre-decay. Even worse, you're looking at how, right when they're down at that sulcus, where the gums and the teeth meet, that's all working to loosen up the teeth. This woman who is possibly pregnant could have a low birth weight and or preterm baby. And she could lose all her teeth. I know I've seen this. I've seen otherwise what look like very healthy people shock me when I looked in their mouth. They're 35, they don't have any teeth. And they say, I don't know what happened, but during my pregnancy they got worse. And this is not an uncommon picture. Even worse. Much the same, but just worse. The more you let this go, guaranteed this person is going to be in trouble. What color is decay in its earlier stages? It's not dark, it's white. So this is just, every tooth here is decayed. And look at those gums too. This may not be a person with, this is probably a person with coexisting conditions. Could be sickle cell disease, could be, because you're looking at this gingival hyperplasia as well. So this is not a good sign, but this is like an emergency kind of situation. And this patient may well have sickle cell disease given these things. There's another term for them. I'll show you a better picture in a second. But this is a tough one. This could be a child with a developmental delay. My cousin in Atlanta pioneered in dental treatment of the developmentally delayed. Nobody was doing this, and he went to Children's Hospital, Eggleston Hospital, and said, why don't we start a program? Because all these kids are coming in with these terrible mouths. This was a neglected area of institutional care. So this is what we don't want to see, but what we need to treat. This is an infant that is headed for trouble because that bottle caries has gone into total decay down through the roots. This is a surgical intervention. This is a major, awful situation. As is this. This is the bottle caries that didn't get picked up. You see this? Guaranteed 100%. This child went to bed with some liquid in the mouth, and that's what caused that. Notice where decay starts. It doesn't start on the front, or it can, but you see it on the occlusal surfaces. So this is, again, very bad decay. And again, doesn't look bad, but that white is the tip-off that this child has decay. This is an adult who had GERD and might have been a pregnant patient with hyperemesis gravidarum. Not only do you see the effects on the enamel, just dissolving it here, but this is so bad that she's already had either a root canal or a lot of dental work on that one incisor. What is this? Any idea? Have you seen this? You've seen it, but do you want to try to describe it and posit a guess? Well, it's a misnomer. And it has a name, begins with a P, pyogenic granuloma. And it is neither pussy or a granuloma. It's just one of those things. It's something too that you can send to an oral surgeon to desiccate off, with electric cautery, or you could watch it. It'll probably resolve. It certainly is a lesion of pregnancy. And in fact, it used to be called a pregnancy tumor. And it will completely resolve with pregnancy. Another example here, pyogenic granuloma. That's one of the more common things that I've seen on quizzes. And probably another example of that. It could masquerade as other things, gingival hyperplasia. There are a few other differentials, but that's basically. Now this is a little curious. Look at those little kind of fuzzy things in a missing tooth socket. Try your best. Just throw out anything you see there. Well, you see it's a man. We don't necessarily see a whole lot of problems with his teeth other than that missing one. He's got some decay in the first premolar. It looks like almost like a little kind of indentation there. But these are really strange things. They look like a sea anemone. So number one, what do you think the lesion is? And number two, what do you think the ultimate diagnosis is? Lesion is a verruca. That's a wart. That's a papillary wart, right? And that's not a common place for warts. So this is probably an immunocompromised individual. And indeed, this patient has HIV. This is on the lateral aspect of the tongue. Not a great place for any lesion to be. It's going to warrant a biopsy. Turns out to be a fibroma, benign condition. But keep that in mind for a little bit later in the second talk, where we're going to get really heavy into what tobacco lesions are. Again, probably another fibroma, could theoretically be something else like a mucocele, but it's probably not malignant. Now that one, I would be scared about. Remember I said red, the brighter the red, watch out for it. That's got to be biopsied and removed or both. That turned out to be a cancer. This is an unusual condition. You don't see it except in certain people. Who might you see this condition in? You would probably see it in someone who doesn't have great oral hygiene. You would probably see it in someone who smokes, and probably see it in someone who drinks alcohol. You're describing this as grayish, kind of velvety. This doesn't look healthy, does it? It's called leukodema of the buccal mucosa. Not uncommon. That's what you see when you look at people who are heavy cigarette smokers or pipe smokers or cigar smokers and who drink. Now that is one of the more important slides of the day. Why? Because if you recall the polio talk and my fervor about why we're not getting vaccinations up, we're seeing the reemergence of conditions that I've seen and I hope you would never see, but you're going to see this condition. And if you look in the mouth, you'll confirm the diagnosis. So what is it? What are they? Yeah, say it out loud. Begins with a K. Yeah, say it. Coughless spots. Right. The reaction inside the mouth is probably an inflammatory reaction to the measles. You're going to see this. It's not good. But you will know it even before you open the mouth, because these kids are going to have watery eyes and coughing, and they don't look good, and they've got the rash. How about that? Describe what you see. A what?
Linear.
Yes, linear what?
White.
White. Linear white, that's fine. So it has a name called linea alba. Benign, what's it caused by? And where is it located? It's located exactly, yes, exactly where you buy. Completely benign lesion. Usually it's bilateral. Benign lesion. Not to be confused with this. I've mentioned this earlier, but these kind of lacy things in the buccal mucosa, or it could be anywhere in the mouth. They look like Martian lunarscapes, with the different canals. Wickham stria, which means this patient has the condition that has Wickham stria, which begins with an L. Yes, lichen planus. So forcefully said. That's great. I mean, just so confident in this. So where do we see lichen planus? We can see it commonly in the mouth, in the genital area. It's an autoimmune condition. It's got several forms. It's a protein condition that I don't like. I don't like lichen planus one bit. It's 20%, only 20% totally resolved. So think about that. You can get steroids. There's lots of other new medications and immunomodulators, but I don't like this at all, and I hope we won't miss it. Another example. And what about that? That tongue looks maybe familiar. How would you describe that tongue? Good news, everybody's thinking about this one, right? That's good, because the first inclination is to say it's what?
White.
Yeah, it's white. Good start. The first inclination is that this white tongue, thank you, is
Scrape off, or does it not?
yeah, the scrape off, which means if it scraped off, it would be candidiasis. So you look at that, that's candidiasis. But there's something about that. It's not a uniform thing, not that Canada has to be uniform. But that's an adherent whiteness. And that turned out to be, well, good guess, leukoplakia. No, it's lichen planus. So that that's not good. And these dots around there are supposedly the clue to erosive lichen planus. Now that you probably will make a diagnosis of. What is that patient missing? It's a pretty good question. What's missing in that patient's life? What?
I said taste buds.
Taste buds? Yes, good point. They are missing. Yeah, she's lost a lot of taste buds. Good. And to get to that state, what had that person been missing in that person's life that one consumes or should consume? B12. So you've got a glossitis. They call it a rhomboid glossitis. This is a B12 tongue. And how about that? Do we have a name for this? Surely you jest. Surely you jest. This is the most fun diagnosis in the whole talk. So surely we could have some fun with this, right? Looks like almost little islands of lost papilla, right? Well, that was a great movie, The Islands of the Lost Papilla. But this is in fact, no, I don't think it was a movie actually. This is called a geographic tongue. Have you heard of that, remember? So what's the harm of a geographic tongue? Probably not much. There has been some associations with other conditions. Well, yours truly has a geographic tongue. As far as I know, no associated conditions. Knock on wood. Okay, so here's the story. Dr. Drinan was a famed oral pathologist at University of Buffalo, where it snows. So he's in his office. It's late in the afternoon. The whole university was closed because of a sudden snowstorm. The door, there's a tap at the door. He goes to the door, opens up, and this lady is all got snow coming down, and she's doing her glove. Says, Dr. So-and-so sent me here to get a second opinion. He said, where are you from, madam? He says, oh, I live, it was 100 miles away. She got herself through a snowstorm to get it because she was so worried about this condition. He said, well, madam, come in. I'll be happy to take a look and show me what is your concern. And she opens up her mouth, and this is what he saw. So let's say you're in the position of Dr. Drinan. You know that this lady has just driven 100 miles through a blinding snowstorm and has to go back. And you know this is perfectly benign, and you can't quite necessarily say, oh, it's nothing. So how did he handle it? He asked her more history. He says, well, ma'am, oh, it's very interesting. He says, has this been just coming up, or have you had it a long time? Oh, I've had it forever. I said, okay, and he writes that down. He says, is it any other member of your family has? No, nobody else has it. He says, honestly. He says, is it painful? He said, no, it's not painful. And said, okay, he writes that down. And you've had it a long time. Yes, I had it a long time. Thanks, Inc. He said, I don't have to think about this. He says, yeah, I'll explain it to you, but it might be a little hard. He says, you have lingua geographica normalis chronica non dolorosa. Meaning she has a chronic geographic tongue with no pain or anything. And she goes, oh, really? Is it serious? She says, no, madam, it's just fine. You can live with this. It won't cause you any problem. She was so excited. She said, oh, thank you so much. It was worth the trip. But again, perfectly benign condition. And another example. Now this, I've mistakenly, the last time I gave this talk, I was slightly in error because I was trying to illustrate that candidiasis doesn't have to be white. You could have an erosive candidiasis, a bright red candidiasis. This, in fact, may well be that, but the article that it's in, and one of the articles you'll get, it had this. The article indicated that this is a gentleman who used his inhalers excessively. So this is really a raw tongue and irritated, a contact dermatitis, really, from the use of inhalers excessively. And that's that rhomboid glossitis that I mentioned. It's actually an erosive candidiasis. So that's candida, believe it or not, as is that one. And not so fast, because that's what we call something slightly different. You know that one? Common. In fact, one of the PharmDs, and I wrote a case report about this, due to amitriptyline. It's hairy tongue, or black hairy tongue. Elongated papilla. And how do you treat this? Sometimes you actually have to take a scissors and cut off the papilla because they're elongated and they turn all sorts of colors. Who gets these? People who have poor oral hygiene, who smoke heavily, and who also drink heavily and don't brush their teeth. Now that's not to be confused with this lesion. Any description here, a small white lesion on the tip of his tongue there for a long time, unable to be scraped off, unable to be changed in any way, and a very frustrated patient. Benign? Not benign? What do you think? Not benign. Hairy? It's a hairy leukoplakia, which is bad, not good. This is associated with HIV, which he had. Good. And that, we've maybe seen a couple of patients. I've seen a couple, fortunately not coming in this way in the emergency room, but they could breathe. But this is classic.
Allergic?
Yeah, cold. It's an anaphylactic reaction, cold. Angioedema, right. And it's most likely due to, most common cause, well, you can't always say, but in this instance, this patient was hypertensive. So it was probably an ACE inhibitor. And I have one patient who's had that a couple of times, got her off all the ACEs. This is not good. Do you know what this condition is? You have to look for this, but you have to also be aware of which patients might get this, and you might know who could get this. It has to do with the medication that they're taking, that you and I might have put them on, because we wanted to protect them. They would mostly be women. They would mostly be women over 65 who've had an abnormal DEXA scan, because you were looking at protecting them from osteoporosis with bisphosphonates. So that condition, therefore, is osteonecrosis of the jaw, and the treatment is very difficult. It's a surgical treatment. It's almost thankless. There is some cure rate, but it's not good. I've had people say, no, don't give me those. No, I read about that. I don't want to go on this. I'd rather get osteoporosis. So we give these bisphosphonates very commonly. I prescribe them too, but I think you got to keep in mind, this is not a rare condition. That one, much more common. We don't often look for it, but I can tell you that just about anybody who smokes is going to have that. That's nicotinic stomatitis. And you wouldn't know it's nicotinic. You'd know this would be nicotinic stomatitis because that's green. That was a prize-winning photo shot by a dentist many, many years ago. That's entirely due to smoking. That's another example of erosive. There's another word for it. This is a candidiasis that's adherent. This is not good. This is a real serious infection in that particular patient, probably immunocompromised. Another example of what you see if you take off the denture, and that's what you can often see under the dentures if you look for it. We're getting to the end of this talk, so we almost start where we were in the beginning with the lips. And what do you think is going on with this child? Yeah, it's a chelosis or cheilitis called, there's another name, fancy name for it, called Perlesh. It's probably due to licking the mouth. Is it benign? Probably benign. Do you treat it? Yeah. What do you want to treat this with? Believe it or not, there are a variety of treatments. It's primarily a candle issue. It's primarily likelier than not to be candida. Looks like that, right? But because there may be a secondary bacterial infection in there, some people treat it with low-dose steroids. So you can treat it with antibiotics, you can treat it with antifungal, or you can treat it with low-dose steroids. So it's probably going to clear it up, but that's not an uncommon condition. Now that, I've alluded to that before, this baby has been doing what? Living, drooling, having fun, eating food that drips all over her, or him, whatever. Contact dermatitis from saliva and whatever else. That is shown in some textbooks. It's in Habib. I think almost this exact slide is beware. And it turns out in this child it was a dire condition, but I only show it because it looks like the lips are a little brighter. So what should the light bulb go on when you see bright lips? But it wouldn't just be the lips, it would be where else? The hands, the feet. They'd also be bright red, swollen, maybe even peeling. Yes, say it out loud. Yes, we've seen a couple of cases in our evening clinic That's the only time I think the Pete's people ever thought we were really cool. No, that was a joke. Wait a minute. So the fact is that we will see this. But this is not. But I just show it as an example of that Kawasaki's is not an unknown condition. This turned out to have been a mercury poisoning, but that's a whole other story. And again, we start pretty much where we began. We have a couple of conditions here. We see this chylitis, angular chylitis, the angles of the mouth. We also see actinic damage. See that whitish discoloration of lower lip? Very subtle, but that's that condition. And that makes it even worse. That's an erosive chylitis. That's going to go to surgery. That's far gone. That guy has probably got many other problems. Those are, we've said it before in this talk, two little aphthous ulcers, right? Remember the difference between herpes and aphthous ulcers? You're going to get on the keratinized epithelium, the herpes. You're going to get on the unkeratinized mucosa, the aphthous dermatitis. Not 100%, but that's generally your rule. Can be painful. Now, keep in mind, if you had a whole slew of those, keep vaguely in mind things like ulcerative colitis and Crohn's disease, too. Crohn's disease can affect the entire digestive tract. That reminds me of the first slide we saw with the amalgam tattoo. That's a traumatic ulcer from the braces. A lot of it is just adding one and one. What about that? What about those little areas along the upper lip? Good, bad, and different? What do you think? The hint is that they're painful. So this patient, therefore, would have little vesicles. Oh, herpes. I like that diagnosis. It's better than herpes. It's, oh, herpes. Good. I appreciate that. That's good. I'm going to add that to her. No, I don't need, I think, oh, herpes. Yeah, that's what this is, herpes labialis. And that's what that really, this kid is in pain because that's what you see. And that's gotten into the tongue and everything. So with that in mind, I think we've reached the end of that. If you like to stretch, but I've got to finish the rest of this because this is like this specific topic with all the grungy lesions. But can I continue on? Can I do it? Make it a twofer? That way we might get out a little bit early. Good. So a couple of quick stories. First of all, the smokeless tobacco issue has not gone away. We've heard about it, and UAB played an important role in this story. A guy named Dr. Brad Radu, an oral pathologist, in the 1990s, started looking at who gets oral cancer. And what do you think he found? What is the group that most gets oral cancer? What are they doing? Smoking and drinking. Well, what about smokeless? You put it here, it doesn't matter. No, way down the list. So he was thinking, now wait a minute. If everybody's raising Cain, all these people, he's like Blum, he's bad for you, he's smokeless is horrible, why don't we stop and take a deep breath? Maybe we could get people who are smoking to switch to smokeless. That's an industry term, smokeless tobacco. It used to be called snuff. But somebody got the right idea to call it smokeless. No smoke and you smoke less. Clever. Guy probably living in a mansion right now for just that one word, smokeless tobacco. So I call it spitting tobacco or oral tobacco. But smokeless is, I think it's too nice a word. But in any event, he said, and he wrote a book on this, let's try advising people who don't want to stop using nicotine to use a safer product. And he made his case. And what happened was he was condemned by just about every dental organization you can imagine. And the National Institutes of Health actually had a dental committee, and they literally passed a resolution condemning him. I thought that was unfair. I was intrigued by his thesis. I didn't agree with it, so I called him up. This was before I got here. And I said, first question I got to ask you, by any chance are you taking money from the United States Tobacco Company, which makes most of the smokeless tobacco? He said, no. I just discovered this, and I've been writing about it, and I just think that's what we should be doing. It's harm reduction. Well, by the time I got here in '99, turns out he was taking money, because the U.S. Tobacco Company contacted him, and they were giving him a lot of money through UAB to do this, to further this. So that's a backstory. And back when I was at JAMA, Journal of the American Medical Association, I was assigned to do what they used to have a section called Q&A. So this particular week's issues, I was given 4 questions that had come in from physicians on tobacco. And one of them was on smokeless tobacco. So that's me writing the answer, what is the current epidemiology of smokeless tobacco? How bad is it? And so, I thought I wrote this little fact piece. I did a lot of research, and this took me a few weeks to condense it and write it. And lo and behold, it became an Associated Press wire service story. It went all over the country. Doctor says snuff and chewing tobacco are also risky. Well, I was trying to say it's not as risky as cigarettes, but still, the story got to be national. At the time, I was heading up a group called DOC, or Doctors Ought to Care. If you've heard of Tar Wars, we started that. That was one of the projects that we did. Not just on smoking, but a lot of health issues in general. We got family medicine residents and med students to go out to schools and throughout the community, and we did a lot of fun things. And in fact, well before I ever came to serve on the faculty, there was an article in Birmingham News about our efforts. So that's me way back, doing DOC, or Doctors Ought to Care, where I pull off my shirt and say, faster than a speeding bullet and so forth. And this is the second story. This is the irony of this, dental snuff. Think about it, it's going to do something to your teeth. I was a med student, and I was a third-year med student, and I was doing an exam on this lady, sweet little black lady, just so nice, and I said, can I look in your mouth? And I had the natural light coming up from the window, and I looked in her mouth, and I saw this black fungating mass. It was horrible. And I was so taken back, I ran to get all the other attendings and the other med students that came pouring, about 8 of them. It was show us, we got to see. And I asked her to open her mouth again, and it was perfectly normal. There was nothing in the mouth. And they said, come on, you're an idiot, as the idiot said it, so. And I was embarrassed, and I couldn't figure this out, and I looked under her bed as they all left, and I saw there was a Coke bottle dripping with the same black mass. She just spit it out to be polite to the other doctors that were going to come in. That was what's called the quid of her snuff. She was the user of snuff. So back in the 70s, when I was a med student, that's the primary users of snuff. There were cowboys in the West, and there were sweet little black ladies in the South that used snuff. The other story has to do with DCH. Not long after I got here, I was asking where so-and-so was on rounds. One of the residents wasn't there. And the comment was, oh, he's down at the snack shop getting his Skoal. Okay, that means when I got here in 1999, they were selling Skoal oral tobacco in the gift shop of DCH. Just want you to know. So I wrote to the head of the hospital, and I said, Bill Castle, I said, gee, Bill, it is fascinating. I didn't realize the gift shop still sells tobacco products. And I said, I got a call from the science writer for one of the newspapers asking me about smoking in hospitals and the use of tobacco and by hospitals, what they're doing. I said, do you think I should tell them that DCH sells tobacco? And they said, no, don't do that. So they stopped it. That was one phone call. But the other thing was, early in the 2000s, we couldn't figure out how to lower this lady's blood sugars. They were sky high. She was admitted for her diabetes, out of control. And we were literally puzzled. She's in a controlled environment, and her sugars are still sky high. I was sitting in the room talking to her one day when this guy, sweet little young guy, came in, had a paper bag with him. He goes, "Hi, Grandma. Here, I got you Dixie Peach." Dixie Peach was a brand of snuff. And she says, "Oh, good." She takes it and puts it in her mouth. Do you know what's in snuff products? Lots of sugar. End of story. Molasses, in fact. So that was the irony of a product called Dental Sweet Snuff. All right, a couple of minutes. Trigger warning.
According to the National Institute of Health, 10 million Americans use snuff or chewing tobacco on a regular basis. At least 3 million of these users are under the age of 21. Does this increasing use of smokeless tobacco pose a serious threat to public health? From the Network for Continuing Medical Education, this is Smokeless Tobacco, a new threat to public health, with Dr. Thomas Robbins, Assistant Professor of Surgery, Department of Head and Neck Surgery, MD Anderson Hospital and Tumor Institute of the University of Texas System Cancer Center in Houston. Exploring the problem with Dr. Robbins will be Dr. Alan Bloom, founder of DOC and former editor of the Medical Journal of Australia. Dr. Bloom's special interest is disease prevention and the effects of tobacco and its promotion.
In the past decade, there has been a rise in the use of smokeless tobacco in this country. Smokeless tobacco includes snuff and chewing tobacco.
1986.
Snuff refers to powdered tobacco. In the United States, snuff dipping is applying the powder to the recess between the lip and gum. Chewing tobacco is shredded tobacco, usually mixed with some form of sweetener, either molasses or syrup. A quid refers to a small portion of snuff or chewing tobacco, and a chaw is a large portion of a golf ball size that people chew. This habit, particularly snuff dipping, was once traditionally limited to a small population in the South. Now it has grown to include more than 10 million users, many of them teenagers. Tom, how does consumption of cigarettes compare to smokeless tobacco?
The overall use of tobacco has decreased from 1970 through to 1982. The yellow line shown in the graph represents the use of tobacco for males and females. The strongest downward trend has been in the males over 18 for cigarette and cigar smoking. Cigarette smoking in women has actually continued to rise. Most importantly, for purposes of this discussion, consumption of chewing tobacco is rising steadily.
Tom, as a cancer surgeon specializing in the head and neck, how do you feel the increased use of smokeless tobacco is going to affect the overall incidence and mortality due to cancer?
The major risk factors for these cancers are alcohol and tobacco use. 90% of patients who develop the disease use one or both of these products. According to the National Cancer Institute, more than half of these cancers arose in the oral cavity and the oropharynx, which of course is the area most at risk for users of smokeless tobacco. Other head and neck cancers include such areas as the larynx, the thyroid, nose, cervical esophagus, and the nasopharynx.
Well, I just heard from him this morning because I wrote him yesterday and said I was going to do this talk, and I sent him a copy of this video, which he probably hadn't seen since we did it. He has since gone on to have a stellar career in head and neck surgery, one of the premier head and neck surgeons in the country. He's been president of the American Head and Neck Association, and he started a cancer center in southern Illinois. He goes to Tanzania, where he and his wife, who's also an otolaryngologist, do mission work. He's just an incredible guy, and we hadn't stayed in touch, but we're now resuming. We plan on a Zoom to get together. But I want to put this in perspective today because it seems like a minor problem. It's about 5.9% of high school tobacco users using that. The big thing that you hear a lot about is e-cigarettes, and that's a whole separate discussion where it's the number one nicotine product that kids are using. I'm not as concerned about it for various reasons, but it's not meaning that I'm not concerned. But the key thing for the purposes of the population we're seeing is we're in the South, where we have among the highest usage levels of smokeless tobacco and oral tobacco use. Another way to put it is the things that the CDC are worried about is e-cigarettes, which are soaring even as cigarette consumption is going down. That's great, but I think we've forgotten about oral tobacco geographically in this part of the country. It remains a problem. Another way to look at it is to look at the smokeless tobacco profile. Again, these are very small percentages, but those are on average. If you look at the Alabama percentages, it's double what any national thing. We're in the 5 to 9% using group. Another way to look at it is to say that although we're not as high as Kentucky, West Virginia, and Tennessee, or Wyoming, or Montana, where there's a lot of rodeos and so forth, we fall into this same 5 to 10% group of usage. So you go back 100 years, and you might sally up to the bar in an old saloon in the West. You might see the son and the father sitting by the bar with a spittoon. And when did spittoons go out of favor? And by the way, how long have we used tobacco? The answer to that, as I posed in July, is we've used it for thousands of years. We used it mainly to savor it in the mouth, not to inhale. When we got in trouble is when we started inhaling it. So by the 1950s, we saw the epidemic that we created from 100 years of cigarette smoking, that ironically, the smokeless tobacco people started marketing once the smoking results were found. They started promoting smokeless tobacco in the 1970s as a safer form of smoking. So we've almost come full circle of using so-called smokeless tobacco as a harm reduction device. And we don't spit anymore because they've created products that dissolve in the mouth that don't require you to spit. A third story, by the way, was one I got almost hit by whatever the guy was spitting at an LSU football game when I first got here. I knew this would be a problem in the South. So let's just go back to 150 years ago. Welcome, mild and sweet, welcome cigarettes that you can indulge in continuously without any possible injurious effects. Wait a minute, what are they talking about? This is 150 years ago. They were already talking about the injurious effects of smoking. They were talking about the injurious effects of nicotine. And they used a young lady, show her little leg to, entice the guys to buy cigarettes. By the 1920s, women had gotten their equal smoking rights. To keep a slender figure no one could deny, reach for a lucky instead of a sweet. This is crazy. You wouldn't say have a candy bar saying, no throat irritation, no cough, and yet that's how cigarettes were sold, for your looks. Do you inhale? Everybody's doing it. 7 out of 10 smokers inhale knowingly, the other 3 inhale unknowingly. Total nonsense. But even athletes could say they don't get your wind, and they could smoke as many as you please. Inhale to your heart's content. Even Santa got in on the act. Luckies are easy on my throat. Little Johnny, this little guy said, doctor's report on Philip Morris, nobody wondered what stunted his growth. And then more doctors smoke Camels than any other cigarette. This is true. This is how cigarettes were promoted through the first half of the 20th century. At the ANA convention that I went to with my father, you could come home with a carton of cigarettes. And I mentioned in July, when do you think they were still giving away cigarettes at Medical Association meetings? The 1980s. We were not a great, organized medicine. We were still letting the cigarette people get into our meetings. The advertisements, this comes from a medical journal, the real importance of less nicotine in cigarette smoke. They talk about the scientific benefits of smoking. 28% less than what? Than fresh air? It's crazy. Research. The word research has been used to sell cigarettes. Light and old gold instead of a throat treatment. They're mocking. Just like they're mocking, a lot of things today, the COVID vaccines, Nose, throat, and accessory organs not adversely affected by smoking. This is total nonsense, but they got away with it. They put a microscope in a cigarette ad, and you think it must be good. This is it. L&M filters. This is when the filter came out in the 1950s. Are just what the doctor ordered, and that's an actor, not a doctor, in the ad. And what were the early cigarette filters made out of? Asbestos. They were so safe, so pure, they used to filter the air in many hospitals. It's totally nuts, but I'm just giving you the history. And in Time magazine, next to the medicine section, new double-barreled health protection from Viceroy. All sorts of filters that were created to in with the good air, out with the bad air. These were all nonsense. Filters do not confer any health benefit whatsoever, but we believe in filters. And then tar. Remember I did the, doc, I smoke low tar. And I said, but Helen, no, you're getting it, you don't understand. It's not it's tar. What is tar? Tar is the solid condensate that you get if you condense the smoke. It's got 3,000 chemicals in it that can cause cancer. About 40 of them can cause cancer. So I call it carbon-rich anabolic products, or CRAP. And but study Hale's low tar. That was a marketing study where they found people like their brand more than others. But low tar just means low poison or low crap. Carlton is lowest. This was the tar derby throughout the 1970s and 80s. Our patients were being told, if you smoke this brand, it'll be safer for you. Even the government, we use the government figures. Carlton is lowest in tar, the lowest in arsenic, the lowest in poisons. That's what they were saying. Would you go into a store? I like the Starkist tuna because I heard that only has 1 gram of mercury in every can. But that's how cigarettes were sold. It's official, U.S. government reports. And then they had, in the 1990s, this brand. They came out of Philip Morris. It had a little thing. You would stick the cigarette in, but it was their cigarette, and it would heat it. So you wouldn't be breathing the smoke. So that was the early electronic cigarette. It was called Accord. Didn't sell well. And then they had Premier, another clean smoke. And then they had Quest. You would step down your nicotine, like you step down with nicotine gum. And then now, you've seen this one, American Spirit, only natural tobacco. It's just crazy what they get people with thinking, because it's natural tobacco, it's organic tobacco, it's like organic arsenic. And then Eclipse had some way that they claimed that they could reduce the nitrosamines. So they said a cigarette that may present less risk of cancer, chronic bronchitis, and possibly emphysema. Hey, we're not going to cause as much cancer. You have less risk from our product of getting one. Isn't that great? But this was a come-on that was absurd. So it was called low nitrosamine cigarettes. And then this was the ultimate. This was around 2005. Omni, reduced carcinogens. Think about it. a low cancer cigarette. And the first reduced carcinogen, this is not a joke, this was not Mad Magazine, this actually was promoted. It's like jumping, instead of from the top of the Empire State Building, you only jump like from the 90th floor. And this was how cigarettes were being sold. And then, of course, a lot of clean indoor air laws were passed. You couldn't smoke on airlines, so then the smokeless people started promoting again their product as when you can't fly, you can't go to places where you can't smoke, use our product. Enjoy tobacco on a 4-hour flight? Absolutely. People will be enjoying their smokeless tobacco. And then there's, of course, the chewing tobacco with Catfish Hunter as one of the spokespeople, famous pitcher. And another player called Bobby Mercer, who was known as the Skull Dippin' Man, and he even created a record called Skull Dippin' Man.
Pardon me if I seem just a little bold.
This was a hit in the early 80s.
Got myself another dip of Skull.
This was played on commercial radio.
And I keep my little tin of $103 handy in the pocket of my blue designer jeans. Just a piece between my finger and my thumb makes me feel like a million, makes me feel like a long home run. I'm a soul-dipping, skull-dipping man. I'm a soul.
You know, it just goes on and on. So here he was in sports magazines saying, hey, you could get a free sample. There's a lot of kids sampled, and they got this free in the mail. And that started thousands and thousands of kids on this product. Of course, you didn't hear about Göran von Buren, who was a highly scouted baseball player in Wyoming. He was offered a contract with the Chicago Cubs, but he used a lot of dip, and he got oral cancer when he was a teenager. He had over 40 operations. He died at 37, but not before. He went all over the country. He was a wonderful guy. I met him. He wanted his look to show all the teenagers what could happen to them. And he was just a wonderful, wonderful human being, and he talked in great ways about this particular product. And then, of course, Tony Gwynn, the Hall of Fame baseball player for the San Diego Padres, died from a very serious salivary gland cancer, and he was a very heavy user of oral tobacco, and he crusaded in the last years of his life against the use of this product. But this is what we're up against in the 1980s. I'm, Mr. Crusader trying to go into schools and talk to kids about the dangers of the stuff, and they had on their side, thanks, they had that they were going to put a pinch between the cheek and gum of America. This was their goal. And you had people like Charlie Daniels making commercials saying, hey,
music keeps me going in more ways than one. If I'm not riding that concert, I'm flying to one. So I really appreciate relaxing. Just me and my Skull. Skull's wintergreen flavor's #1 with me. Just a pinch gives me real tobacco pleasure without lighting up anytime, anywhere.
Mr. Daniels, smoking or non-smoking?
Smokeless, darling.
Texas too.
Smokeless with Skull or Copenhagen. A pinch is all it takes.
And remember, the cigarette ads had already gone off the air. There was a loophole that let these ads go on for another 22 years. Let me see. No, it was about 17 years after the cigarette ads went off the air. And here's Earl Campbell, known as the Skull Man, a famous football player, who offered the same thing.
This isn't just my job, it's my life. For me, nothing comes close. Nothing comes close to my Skull either. I just take a little pinch and put it between my cheek and gum. Sure feels good. I think going smokeless is the only way to go. And for me, Earl Campbell, this is the only way to spend an afternoon.
Skull, brother. Enjoy tobacco without lighting up. Try Skull, Copenhagen, or Happy Days. That's all it takes.
And they had another guy. They had another guy who had a Skull race car named Harry Gant.
Harry Gant is a Skull Bandit in for a pit stop.
Hi, I'm Harry Gant. When I bring the Skull Bandit in for a pit stop, I come in for a pit stop. Because while the rest of the team takes care of the Bandit, I get to take a little pinch of Skull, put it between my cheek and
You saw this at Sonic, right?
Without lighting up. Now that's what we call teamwork. The Skull's what we call team pleasure. For real tobacco pleasure without lighting up, try Skull. A pinch is all it takes.
Of course, you go to these events, and I've been to more than my share of events. If you've never been to Talladega, it's worth the trip. Just got to take some kind of benzo or something before you go, because No, I would never joke about this either, but it's the tattoos. The tattoos that you will see in one Talladega race are absolutely, they're obscene, they're incredible, they're all over, and that's just the women. But it's beyond anything. It's a sociological imperative when you come to Alabama. You've got to go to Talladega. But I went to the very last school-sponsored race. Winston's. I got my pictures taken with the school girls, the school babes, and the Miss Winston. But here's a typical kid at one of the events with his Copenhagen hat or his school T-shirt. And there's the U.S. Tobacco Racing Company. They called it Cope for a while instead of Copenhagen. And there's me doing my research. And this is their magazine. The company actually had a magazine that they would handle called Heartland, with ads on the cover. I've never seen another magazine that had a tobacco ad on the cover. This was a brand that they made that actually was dipped in alcohol. So you got both alcohol and tobacco. Bourbon-flavored Copenhagen. Rodeo was a very, very big tie-in. And school and rodeo and bull riding were going hand in hand. So we would do what we call house calls on these events.
Sometimes we simply can't let tobacco companies in our communities go unchallenged, which is why Doc makes house calls at many tobacco-sponsored sporting and cultural events. These house calls generate media coverage and serve to embarrass both the tobacco industries and the local groups who are taking their money.
Look what chewing tobacco does to you. We just appreciate it. We have plenty of room for you.
We're not doing anything demonstrating right now, so we're done. We did all we had to do here.
Okay.
Do you guys take any responsibility for what you're doing, allowing these people to come in the door like that?
Sure we do. Copenhagen used to sample here, so they don't do that anymore.
Why not? What's wrong? Why not the sample?
Well, we've asked them not to do that.
Why not? Why shouldn't you allow them to sample?
Stop this right now. I'm with the Rodeo Association.
Yeah.
And we just like to go outside. We'll provide a place for you to do that, and we are going to take you out here in a nice way.
Yeah, fine.
But we're not going to listen to you.
Protests are a little uncomfortable for some, but they bring results. Gradually, these house calls are raising public awareness and laying the foundation to throw tobacco out of sports.
So in the early 90s, when this was done, most major sports, almost 28 out of 32 Major League Baseball stadiums had big cigarette signs. Some had spitting tobacco signs as well. Motor racing, skiing. Marlboro was a sponsor of ski slopes. It was hard to find a sport that did not have some tobacco in it. This was an example of the samples that you could get if you went to Yankee Stadium or someplace where they were handing out. This is in Cinco de Mayo. Big event in Houston where they would have the Skol Fiesta and the lowriders and lots of Skol promotions. And this little thing, all you had to do was just throw a little bag into a hole and you get some huge Skol T-shirt or whatever. And this was actually, believe it or not, at the Miami-Dade Youth Festival in South Florida. Hard to believe, but this is what was going on. And Skol music, concerts all over the United States. This is at Rice University, which was right across the street from the largest medical center in the world. This is people lined up to getting free samples of Skol. Right after I got here, this is around 1998, 1999, somebody sent me these pictures. The world's largest medical center, and a line as far as you can see of people wanting free tobacco samples. This is a little closer to home. Anybody recognize this? Yeah? Did you go to this university? Yeah? That's a fraternity house on University that had a brother who was a Skol representative. So right after the A-Day game, you came out of the stadium, this is the first thing you saw where they were handing out samples of Skol. Around 2009. So I went into the tent and signed up and did my research there too. And it's Skol Bandits. This is what, the bandit imagery, this renegade thing. And this is right across the street. That's DCH in the background. Around game day, they put these up. You'll see these if you look close enough. They're up there for the maximum traffic that comes to town so that you can do this in the stadium. And of course, different flavors, and it's the solution to when people can't use that stuff. So it's a kind of anti-authoritarian product, and they have fruit flavors and ways that you can enjoy whatever. And it's a lot of sexism involved in magazines like this. Where's the chicks? They'll come to you if you use Rooster. Are you kidding? This is like the biggest turnoff in women history, and yet they're advertising it as something they take out. This was the back cover of Playboy, where they had ads like for the Skol Man. This is making you believe that women will love you if you use this crap in your mouth. I mean, that's literally their approach. And it worked. This is manly man stuff. This is more recent ads in the last 4 years. Our triathlon, beer, bowling, and bass fishing. may cause the urge to act like a man. Or when did hitting the quarterback become a bad thing? Really, really nasty material here. Women have spas, men have firing ranges, guns. Let's get the guns involved too. So just as I close the next couple of minutes, just to give you the epidemiologic overview, these are your basic products, the moist snuff, something called snus that's at the bottom there, and the chewing tobacco. This is a poster that we did some years ago just to summarize the collection that I have on smokeless tobacco. And again, as Dr. Robbins showed, the main sales started soaring between 86 and 2001, and consumption and advertising also parallels that. It looks exactly the same if you looked at the advertising. So here's where we are almost today, and the projection in the future. This is not declining. This stuff is still rising. Where the chewing tobacco is no big deal anymore, but it's all these the smokeless products, the dissolvables, the moist snuff, and that is still an increasing product that I think in the South should make us more concerned. Another way to look at it is keep in mind that 5% of teenage boys, mostly white guys, are using this stuff. It used to be when I was in residency, we would look for the bleached circle in the back of the jeans as the way that they were using. Now, believe it or not, you know where they're putting the snuff while they're in school? Between their toes. So you can actually be using it, and now there's one story that was the head of Auburn's sports medicine department. He told me a story of a person. She was playing softball and she got all woozy. He saw this. He raced down to the sideline to meet her, and she stumbled off the field and she sat down, and people were very concerned. And he said, "What's the matter with? I don't feel good." And she said, "What do you think's the matter?" "Well, I wonder if it's my smokeless." He said, "What? What are you talking about?" And he said, "You don't have that. I know. I saw you barefoot. You don't have it between." He says, "That's not where I put it." Okay? I told him to try to write a case report. He didn't want to get into that, but this is absorbable nicotine in bad places in the body. So again, just don't be disturbed by the fact that this is 15 years old. This gives us versus the rest of the country. We are twice as bad in this issue. We're also more undereducated people are using it, more rural, by educational level, less than high school versus more than high school education. You see it's a factor of education. And again, the more recent image is it's flat among women, but that doesn't mean that some women like that softball player aren't using, but it's still going up in young men. Here's Sean Marcy, for instance, and this goes way back to the 1980s, that he was a high school track star in Oklahoma until he got an oral cancer when he was 19 years of age after about 4 years of using Copenhagen. And this is what he looked like. He did not survive. And he probably had an oral cancer very much like that, the only cure for which is to send him to Dr. Robbins to try to take half his face off. And he didn't want to have the mutilating surgery. But if you give people a choice, what do you want to do? You just think about it. That's the image that people think of this product, and it's a tragedy. So again, to summarize, what are the adverse effects of smokeless tobacco? You raise your glucose. Remember that lady with the Dixie Peach snuff? There's a 70% increase of type 2 diabetes just in using snuff. It's, of course, a nicotine addiction. Remember that gingival recession we saw earlier? You're going to see quite a few slides as we wrap this one up. Caries, especially from the grit and the chewing tobacco. And you have something you'll see in a second called smoke dipper's keratosis, which is a leukoplakia, and cardiovascular disease. That's right. Whether through bacterial factors or whatever, or nicotinic factors, there is a relationship between cardiovascular disease and oral tobacco use. So this slide has everything. This has exposed roots with severe dental caries. It's got ugly looking gingiva. It's got kind of an erosion there. This is just mean, and this is and if you notice the coloration gives it away. That's a tobacco user. So that's dire. Another example, classic, I know what you do, you use oral tobacco products. There's your gingival recession. Once you see anything below here, that's oral eroded gingiva. That should be documented when you see a patient. Or root caries, that's the other term for what you're looking at with that brown discoloration. There's your smoke dipper's keratosis. That's called rugated or ruga. Looks like a stomach lining. this wavy thing. That's a classic lesion. So there's a little kernel of good news. Yes, that is a premalignant lesion. But guess what you have to do? Stop using it, and it will more than likely resolve. There's a pretty bad case, but that's the smoke differ's keratosis with an erosion there as well. Not good. And root caries. So there's another classic example. Just remember those waves, and you will see it. This is a horrible, horrible cancer in the palate. There's what I alerted you to earlier in the day. That doesn't look like much, but remember where the location is, the lateral aspect of the tongue. And what color is it? Well, it's not photographic flash either. That's a kind of a white lesion, all right. So that's a leukoplakia. But look at the angry tissue around it. That's a kind of a mixed bag, and that's the worst kind. A mixture of leukoplakia and erythroplakia is the worst you can have. Erythroplakia is far worse than leukoplakia. That's pretty much an erythroplakia. Look how awful, macerated and red that tongue is. That's got to be cut out. That person's going to lose half his tongue if he's lucky. There's another leukoplakia and a lot of other bad stuff, maybe even a mixture of leukoplakia and erythroplakia, a horrible cancer that doesn't speak well for his survival. There's a leukoplakia and an erythroplakia, more of a erythroplakia. That's maybe the worst slide I've shown today. That is absolutely horrible, but it's subtler than you might think. So you look at those who already are forming lesions, you have a third of kids who are just using this. You can identify some sort of lesion. Not too good. Even in former users, you can still find these, but they're much, much less. So the prevalence of smokeless tobacco lesions in adolescents 12 to 17 by duration, the more you use it, the more you're likely to have some kind of lesion. The relative risk by years of use, obviously the same thing. Look at that risk, 47-fold if you've used it 50 years now. Again, 1 to 24 years, though, has a 13-fold increased risk of cancer. That's pretty substantial for the use of just 1 to 24 years. And here's that cardiovascular thing. Again, I don't know the full association, but that's your increased risk, upwards of 3-fold increase in cardiovascular mortality of men using smokeless tobacco. So lastly, this wonderful term called harm reduction came into vogue in the tobacco field when smokeless was being promoted, and now with e-cigarettes. And it's divided the public health community into people who say, well, we don't want to be prohibitionists. If they can do well with just nicotine, isn't that safer than having them inhale? Yeah, I agree with that. But it doesn't mean we should be encouraging remaining on nicotine dependence, because you might just regress and go back to cigarettes. I think we can get over these. It's not as hard as people think to get over tobacco products. But this has taken an enormous, to me, I don't like the term harm reduction because it implies there's a way that you can safely use this product. So I was part of one of the early seduction of harm reduction conferences where we fought back against this notion that, oh, just recommend a safer form of tobacco. And here's the theory of smokeless as tobacco harm reduction. It's 90% less harmful than smoking. Well, again, what percentage of jumping off the Empire State Building are you reducing? They quit by using smokeless tobacco instead of cigarettes. Okay, I don't think that that's impossible. I haven't seen it. What happens in our population, take it from me, is that they wind up using both. I've had one patient who is the head of buildings and grounds who got off cigarettes, but still used oral tobacco. And he was pleased to get off the cigarettes, but he couldn't get off the oral tobacco. Snus is something you might not have heard about, but this is what was happening in Sweden when they claimed to have reduced tobacco-related mortality after World War II. When cigarettes were in short supply, they had this loose tobacco called snus that people in Sweden used, and they had indeed one of the lowest rates of lung cancer. So they attributed it to having used snus. And I don't think necessarily that that's the whole story. I don't think there's sufficient data to show that smokeless tobacco can be safely used as an alternative. Again, given the choice, sure, go ahead and use it. But again, I don't think you should be comforted by the notion that you're not going to get some of the dire things. There's no data on risk reduction of people who smoke who switch to smokeless tobacco. And did snus really do all that? And if so, why hasn't that been generalizable in other countries where they could have promoted snus? And this is what it is. Camel makes a brand. You don't see it very much these days, but it was big in the early 2000s. They actually had to teach you how to use it, because this, you don't need to spit, it just dissolves in your mouth. And they used the college guy magazines with this was the centerfold, so making fun of the whole thing. And they had rock concerts, the snooze concerts for Camel, with Rock Your Own Anthem, making it really cool to snooze. And fortunately, this is sort of faded. I don't think it was really too smart. And this is another way to get around smoking. They used it to promote ways that you could still use tobacco in spite of the fact that New York had instituted a smoking ban. Marlboro got in on the act for a while, and if you went to their website, you could see the Marlboro Smooth, free to enjoy, Marlboro when you want it. Simple, they would teach you how to do snoozing, perfected in Marlboro country. And you could go on their website today and see all sorts of similar things. Even fitness magazines were a prime vehicle for Skoal and other forms of oral tobacco. This last is, imagine a morning workout. So he goes out with his dog, he gets his workout while he's using his carcinogen. This is a collage that my colleague made of some of the collection that we have at the Center for the Study of Tobacco Society. If next week, during Research and Scholarly Activity Day, you have a chance, come visit the Tobacco Center. We have an exhibition in the vitrine near where the posters are going to be. And with that in mind, I encourage you to drop me a note, let me know what you think. This is in my office. This is a binder of articles that some of which you'll be getting in one of the emails that Jeremy will be sending out shortly. These are the books that you're welcome to come and use. We can talk about this issue. If you've got cases that you'd like to talk about, or if you've had some success and people give you good feedback, let me know. But thank you, and thanks for letting me do this within the time. Any questions, comments, anything at all, experiences?
When you're back in the day, how did you get into that production? Do you have your own show?
Oh, that was something that I had done talks on it, and somebody at they said word, drug company, said, would you like to make a film about this?
Yeah.
And they wrote to me, and I gave a little proposal, and they flew us up to New York City where we made that film.
That's really cool.
Yeah, so the film is actually pretty current if you watch the whole thing. It's 20 minutes. So we have a copy of that also. But in any event, appreciate it. But I'd like you to get involved in this. And this morning, a few of you did attend Dr. Ed Anselm's virtual grand rounds on getting reimbursement for smoking cessation. You'll be out of practice soon, and you could be amazed. It's not for your self-interest, but you can feel, well, I've done something. I haven't just said, here, click the box and take Chantix. He was talking about how we can really get involved, and people appreciate when you raise this issue. So it's no longer ask, do you smoke? It's, you can tell people who smoke when they come in the office. You go like that. But you can say, I want you to stop. Come on, let's do it. And that in and of itself will enhance your approach. So, good. Stay tuned, and I hope you enjoy this field and get a lot of success in working with patients.
There's nothing more